Emily in 5.
Thank you. Okay, welcome everyone to Maternal and Infant Health Canada's educational seminar series. To start off, I'll just explain a little bit about who we are and what we do. My name is Dr. Emily Solomons. I will be the moderator today. And Maternal Infant Health Canada is also known as MyCan, and we are comprised of doctors, researchers, traditional medicine practitioners from both Canada, India, and around the world. Together, we aim to work closely with local healthcare workers, traditional medicine providers, governments, and community members to improve maternal and infant well-being and reduce preventable maternal and infant mortality in India and globally. MyCan recognizes that the only way to make a true lasting impact is to look at all the determinants of maternal and infant health. Our pillars include health education and clinical skills training, community economic development, innovation, and research and accountability. This webinar today, which is part of our first pillar, is on the COVID-19 response in Kerala, India. And then we have thoughts and commentary from Vancouver, Canada. Our main speaker today is Dr. Vijay Kumar. I hope I'm saying that correctly. He's a professor and head of the Department of Community Medicine at Amrita Institute of Medical Sciences and Research Center in Kochi, Kerala, India. He is the Honorable Consultant for the State Health System Resource Center, the Government of Kerala, and also the Honorary Secretary for the Health Action by People in Kerala. Our discussant today is Jan Hayek. Dr. Hayek is an infectious disease doctor currently based at Vancouver General Hospital in Vancouver, Canada. Where he is one of the doctors working with the COVID isolation ward. He works to promote global health equity and works part-time in northern Uganda, as well as in the downtown east side in Vancouver. He provides clinical support through telemedicine for Doctors Without Borders sites across the world, including sites in India. As with all of our public webinars, because we get people who are physicians and researchers, but also people who are part of the public, I do, sorry, one second. Let me just move that, sorry. I do have to do a little bit of a disclaimer. This course and handouts may contain general information about medical conditions and treatments. The information is not advice and should not be treated as such. Now, for everybody who is tuning on, if you have questions, we really want to make this a discussion. We'll first start off with our lecture, but then after we'd like to really have a conversation that happens and questions. So if you have questions throughout the lecture, please, there is a chat box at the bottom. You can ask your questions, we will capture them, and then at the end, we can actually ask both of our speakers the questions. So yes, without further ado, why don't we just go right to Dr. Vijay Kumar.
Thank you. Thank you, Emily. So, first of all, I should thank for Emily, and Dori for giving me an opportunity to talk to each one of you. Except maybe one or two, I have never met anyone. I hope my pronunciation is okay. Fine. So, good evening and good morning. It's really nice to use this platform to communicate. I am a person of age 90 and not actively involved in COVID control activities in the state, but an onlooker, a passive onlooker, a critically looking things around my environment and drawing certain conclusions, which I share with my young colleagues in my organization. So let's start. And Emily, can you tell me how much time do I have precisely? I'll adjust my time. It is elastic as far as I am concerned.
We'll say around 30 minutes ish. Yeah.
How many of you have seen these pictures? Can any one of you tell me? I want some feedback once in a while. At least one of you can very well tell me. Does it resemble somebody? Some non-picture?
Mona Lisa.
Is it? Okay, just keep that in mind. This is just we are just starting, and again we will come back to this picture at the end of this session. Okay. So this is in a nutshell what the world around is experiencing the corona pandemic. For want of time, I am skipping these parts. Among all the cases, there's an apparent reduction in case fatality in India, and the number of cases are now going up every day. But it's not that much as you will expect. The rate of increase is not that much as you have experienced in many of the European countries, or maybe in US, or currently in Brazil. But still the cases are increasing. And within India, the spread is not uniform. I don't know how many you may be able to recollect that India, there are 30 states are there, and all states are not equally affected. 4 or 5 states contribute to around 60 to 70% of the cases. Maharashtra, Tamil Nadu, I don't know how many of you can read all these names, but Kerala is the lowest one, lowest row. You can look at it. We have, when we have prepared the slide, there were 3 deaths, but now the death has gone up to 6, and total cases has gone more than 1,000 after May 17. But the doubling time, look at it. Doubling time, when you compare with other Indian states, doubling time is comparatively positive in this situation in Kerala. So the government of India response to the corona epidemic was really quick enough. They have taken their measures to upgrade the health infrastructure. Lockdown was imposed, and many around the world. I was seeing France 24, BBC, Al Jazeera, or even national and channels. Everybody, at least some of them were extremely critical about the tough lockdown which they have imposed. But by and large, time has proved that that decision was reasonably good one, even though it had a lot of dark side towards it also. Then there was good communication, public communication, and they could rope in reasonably good international partnership. These were the major initiatives by Government of India. One of the major dimension of detection is testing. Does all the states test more or less equally? This is a question that everybody was putting. Cases are low basically because the testing is low. But look at it. There are states which were testing for every case per million. TPM means test done per million, and CPM means case per million. So if you take the ratio, some of the Indian states were testing around 200 times than that of the cases, like Assam and Chhattisgarh. Other 2 or 3 states, maybe 100 times, Karnataka and Jharkhand. Kerala was testing 50 times that of, for every case you will do roughly 50 tests. Kerala, Haryana, and AP. There are states which were performing less, 20 times the case. Rajasthan, UP, and Tamil Nadu. Relatively poor was Delhi, Gujarat, and Maharashtra. In fact, you should understand the last 3 is contributing to nearly 50% or 60% of the cases in India. Testing in our context is the cost is totally borne by the state, not by the individual. I know this is a maternal and child health platform. I was struggling to actually collect as much information as I can with how it is actually affecting the women and child. But you know, because of the lockdown, the communication channels are less. You cannot go around and meet people. There are a lot of hardship. So this is all what I could garner. There's a gender dimension. To start with, the epidemic was 6th April, 76, I'm sorry, it is written as 70%. 76 of the patients were male, first week of April. But by May, the proportion of male came down, and because of the contacts, we are getting the disease, and 64% in May were males and 36 were women. And because of the increasing lockdown, you know, if it was getting extended from 1, 2, 3, 4 like that, and many housewives experience unending household chores because people are there in home, they are not going out, and they are put to increasing demands in terms of maybe getting eateries or drinking something. And because public transport was suspended, you cannot move out. In many cases, access to healthcare was challenged. At least there were reports about the domestic violence. I just cannot say whether it was more when compared to that of the previous pre-lockdown period, but domestic violence was reported. And naturally, the access to family planning measures were also reduced during this period. These were all the dimensions in that angle. And some of the NGOs has collected, this is something like a guesstimate. This is not based on any evidence. Couples unable to access contraception, 2.56 crores. Resulting in unintended pregnancies, 23.7 lakhs. Out of which 14.4 lakhs means 100,000. Okay. Abortions. And unsafe abortion itself is 8.34. And live births 6.79. And they were expecting around 1,700 and order maternal deaths also because of this one. So these are all not exact figures. This is actually a data generated by an NGO. It may not be national level, representation will not be there. So now coming back to Kerala. I don't know how many of you are familiar with Kerala. It's a small state. We are 35 million population and forms around 3% of the Indian population, roughly. 50% of the population is urban, and we have got reasonably good public distribution system, public transport, public education, and public health systems. The picture that you are seeing was taken some time back when there was floods in 2018 and 19, 2 years back. It was really huge one. Huge in the sense it was something unique for the last 100 years. We never experienced something like that. And you know, when floods affects, you know, houses are damaged, people are getting killed, and post-flood epidemics are there. But interestingly, what you should understand is that the state system has came up with something which they can address the challenge, huge challenge, because you know, you should understand that the per capita income Kerala state is not richest in India. It's only 8th rich, or maybe 8th or in the first 10 it is there, but not in the first 5. But the challenge of flood was addressed by, just look at it, these are not national disaster relief army or somebody, these are all lay people working. And you should understand that even the forces came, they were reluctant to go out in the night. And it was the fishermen who took their boats and came up to the other places and saved thousands of the people when actually they were flooded. These are some scenes out of it. So the response was decentralized. And naturally the social capital was tapped, and the healthcare system was rejuvenated and agile during those periods, resulting in managing even the post-flood epidemics. So these are the lessons which actually, these are just last 2 years only. You should understand that that memory was there in the very much there in the Kerala population. And to then we had another epidemic. I don't know how many of you are familiar with this epidemic in Nipah. Just look at it. We had 19th May, first case of Nipah. 19 cases were reported, out of which 17 of them died. And you should understand that again, a good proportion of them, I don't remember exactly, 2 or 3 were healthcare workers because they were running the risk. So more or less the epidemiology was more or less that of corona. And at the same time, mortality was so high. So people knew, the health system knew very well how to contain it. Within 1 month, by July 1st, 2018, Kerala was declared as free from Nipah epidemic. To test that, the next year again we had on Nipah, 2019, in a different district. We didn't have any second case, only one case. And no deaths. So it was in this background that we are actually moving down to the pandemic of COVID. Just look at it. First case was reported in January 30. Maybe that was the first in India. Kerala reported the first case of corona in January 30, basically because January 24th itself, government of Kerala came up with protocols, guidelines, what to do and what not to do about people coming from China. Because during those times, you may be remembering, China was the epicenter, Wuhan was the epicenter of the pandemic. And then we didn't have 3 cases was imported and we didn't have 4th case. We could contain it there itself. The second wave came from March 9 onwards because Europe started. Different parts of Europe, there was a little bit of communication gap. I don't know. Spain started with Italy, but other European countries were also involved. Naturally, the second wave started, but still, we could contain it, and deaths were very low. And now what happens is, until first week of May, the cases were 500, 600 in the range only 3 deaths. And during the second part of the May, after first week, the lockdown in India was a little loosened and trains started coming, road traffic improved, and domestic flight as well as people returning from Gulf countries and other European countries were there and resulting in the third wave. Now it is happening. So last 500 cases were added within 2 or 3 weeks. And now we have got around 6 deaths. This is the curve. So how could actually Kerala achieve something which many others were struggling to achieve? These are the factors which I consider. We can very well discuss about it after the presentation. One is, of course, the past experiences, flood, Nipah. Then our people-centric public healthcare system, we will discuss about it later. Strategies employed by the health system in tackling the spread. Our administrative system is decentralized. Transport and supply of food and other essentials. This has to be discussed clearly. We will. There is a credible leadership, political leadership, I mean. And the approach was inclusive. No one was left out in terms of caste, religion, or even the British or whoever was here. They were also being taken care of, and they were really happy. To start with, they have complained that there was cockroaches, there were mouse and everything in the ward. But they realized that their mortality was much less than their home countries. Strong social fabric fostering the solidarity. Last but not least, it should be the first one, local self-government, Kudumbashree and the citizens of the state. So past experience I have actually narrated. I don't want to go to the detail. If you consider the public healthcare system in Kerala, it has got a long tradition, but it has got its own ups and downs. The funding, the state is spending around 5 to 6% of its state budget on health. Maybe in 90, when the globalization started, 90s and maybe early first decade of the 21st century, investment in health came down, but last 4 or 5 years, investment in the health has gone up. And from 2006 onwards, we have got something called Ardhra mission. That's a rejuvenation of the existing health system. And the state government has started something called a family health center. I mean, a transformation of primary health centers around Kerala. For corona, the state's testing capacity has been augmented. The testing was not, I said earlier, because for every case we are testing around 50 people. It's not aggressive as you are seeing in some of the northeastern states or maybe some other country like Korea or even Germany. Our testing was, so strategies employed were quarantining all the suspects, high risk group. If symptoms are developing, test them. All the test positives will be followed up along with their contacts, and they will be tested whenever they develop symptoms. That's how the actually strategy was put in place. Then contact tracing, and the initial quarantine period was 28 days. Recently, Government of India has reduced it to 14. So initial state quarantine, they put 28 days. And for every patient's route maps and possible contacts were traced using the maybe mobile or maybe even by publishing people in TV, and people could collect all the information. Each case was actually traced to the finest points. And when the lockdown, they have started certain campaign. Internet was made available, and the campaign was break the chain of the transmission of the disease. The decentralization of the governance in Kerala started in 1996. District administration and district collectors are there, they are put in charge. There were control rooms at the state and the district level, and political executives were placed as the person in charge for each districts. And there were identified sites to function as care centers and leverage a broad and dense healthcare system. And so the health system was actually rejuvenated. This is a picture that I'm showing you is the district control cell at one of the state, Pathanamthitta, in one of the first district which had cases from Italy. Then we have strong social fabric fostering solidarity, high literacy rate and socio-economic development. Involvement of religiously, this is something to be seen in many other parts of the world, not only in India. We find that people will be quarreling each other in terms of religion or caste or some race or something. So here the political leadership could garner the support of the different religious leaders. Come, let us sit together, we have to find a solution, there's no other way. And that sort of involvement of local bodies and different civil society organizations is really good. Something to be emulated in other parts as well. The transport and I don't know how many of you or the people from outside can understand. When the lockdown was imposed, you should understand that, say, in Kerala, 3.5 lakhs people are, roughly 10% of the population of Malayalis working outside. I'm sure, Emily, in your place also, within 10 kilometers, there will be one Malayali. Okay. But almost equal number of people from other parts of India is working in Kerala. So when lockdown was set in, they cannot move out. So the government took initiative in ensuring that the community kitchens are there. Whoever is migrant, nobody, even the people in the street no one should go hungry. In fact, it may look a little ridiculous, but the chief minister came up with saying that even the dogs in the street should not be hungry, because if they become hungry, they will be aggressive and biting people. So the approach was really comprehensive. And whether you are poor or whether you are rich, everybody gets their ration for a month, free of charge. Not only rice and something which you use, the staple food here, all the condiments and groceries that you require. That's a good initiative. And you don't have to pay for it again. So public movement was regulated, transport and essential supplies. So essential supplies and free transport was made available. And many of these and the groceries were, delivered to the doorstep. And the political leadership should be saluted in the sense there were so many different types of 18 or 20 committees evaluating daily situations, something like on war food, advising government what to do and what not. Daily briefing of the chief minister on TV. I think that was the one which attracted a lot of viewership recently. Briefing the situation and what the government is doing and what the citizen is expected to do. And the state came up with an economic package even before the government of India has came up with something like that. Then the inclusive approach. Vulnerable sections of the society were taken care of. Migrant workers, we call them as guest workers, because we ourselves, we are actually sometimes migrant workers in Mumbai, Calcutta, Delhi, and if you go to Arab countries, good proportion of that, we know how it will be, we feel how it will be like when you are in these sorts of situation in a different country. Role of self-governments. That's really marvelous, you should understand that. Basically, the local leadership, political leadership has evolved over the period, last 20, 25 years, and they knew what they are expected to do. They are working in tandem with the government. You see certain things over here, these are all actually people preparing masks. Masks were not, we used to have only surgical masks. Whenever the government says we should have mask, everybody should wear mask. So they start the production, local. Then we have got women self-help groups. We call it as Kudumba Sri. 43 lakh members. That means 43 lakh households involved. Out of 60 or 65 lakh households. More than 60% roughly. They worked in convergence with the health and other departments. So many IAC WhatsApp groups were there, supplying grocery kits, small preparing sanitizers, cotton mask. These are all short notice. Once the government, the chief minister comes up with saying, the next day the work starts. The general public should be definitely, I did not find any news where, except maybe in one northern districts, the police has used force in ensuring the restriction of movement. But by and large, people received it seriously and adopted the instructions from the government. I hope these are pictures of lockdown compliance. And today I find that more than 170 Malayalis succumbed to the disease in other countries around the world. In Kerala, 35 million people are there, 6 deaths. 3.5 million people are outside Kerala, out of which 174 died. And the Kerala managed the crisis with most resolve, most compassion, and best results of any large states in India. It was done precisely by building on legacies of egalitarianism, social rights, and public trust. So far I do consider it as successful. It was achieving a low rate of spread, high recovery, and low fatality. The importance of public health system, the social capital, and the active involvement of the people through local government. These are all the highlights of the Kerala's achievements so far. I don't know how the third wave that we are experiencing now is likely to play out, but still we have to be fairly confident that we will be able to manage it. And There were wide acclaim around the world, from different countries. Now coming back to our original picture. And Farah said it was Mona Lisa. And again, this one also, I think it is Mona Lisa. Am I right? If that's the case, what does actually the difference between these two Mona Lisas? That the activities that any government was doing more or less the same. Quarantining, testing, tracing, treating. So the procedures are more or less the same. The canvas is the same. Painting is also more or less the same. The only difference is in the subtleties with which the painting was done. And I'm sure that sort of a creative thinking and the leadership, a state, a citizen, a group, a community putting, we will be able to manage not only corona, even something bigger than this. That's what I feel when I consider the experience of corona. Again, I tell you that I have actually highlighted how we could reach so far. I'm not saying that this is the ideal. There were so many gaps. There are a lot of things which we have to do now, even after the corona, especially ensuring the livelihood of people. So many issues are there. But this is one side of it, how we could actually contain it up to this point. And these words are actually one of my close colleagues' words for you to consider. I stop with that and thank you for the patient listening. I'm happy to take up questions. If something which I can answer, I will, or I will refer and let you know.
Thank you so much. That was really interesting. We do have some questions who have been coming in, but I think before we get to those, I would love to first hear from our discussant, Jan, a little bit about your take on this and questions maybe that you have on it. And then what we can do is I've already been gathering everybody's questions. At the end, we can actually put all the questions out to both of you.
Excellent.
So,
Thank
Dr.
you.
Hayek?
Thank you. That was a tremendous talk. I really enjoyed listening to it. It was, I've not heard that Kerala story before, and just listening to the way that it was handled and the tremendous success. I think it's related. Sometimes people say they were lucky, they're super spreaders, and that has happened in parts of India, I think in Italy there. But some of those things that you talked about were tremendous. Like even the attention, it struck a chord with me that even dogs on the street would be fed because to take care of everybody. And I think it helped you get trust. I'm not sure how you managed to do some of these things, like the food for people. Even in parts of India, I've heard these stories on the media of migrants going and being quite stigmatized it hurt other people actually, not supporting in the way that you mentioned that they're even guest workers. Here sometimes we call expats and foreigners and things, and it's really, really nice to hear that kind of thing. I'm totally impressed. I really I have lots of questions about how you've done it, but I think it's because of the background. I think some of it is how you said that people went through these difficulties before, they've kind of survived them before, and they've realized that that's the way it works, and they trust the system that will work for them. Yeah, it's just amazing. Like, this morning we had a talk with Peru, and Peru, they were ahead of the curve. They did these lockdowns, everyone wore masks, everything, but they're struggling with more than 100 cases per day, tons of it, and people are not able to do the lockdown. They don't have that support. They don't have the buy-in. They don't trust the system. They're, they say lockdown, but then no recourse, no food, no supports. So just tremendous. Maybe I'll just ask maybe one question about the food, say those kitchens. Was that centralized government Kerala response, or was most of it kind of local small initiatives doing it, or how coordinated was that response?
Very good question. And today also I saw a news item, a photo where, you know, a 2-year-old child was nagging the expired mother, unknowingly that the mother has expired for want of food or maybe the adversity that she has faced. Is really, you know, really hurting our sentiments. But I can tell you that in Kerala, none of the guest workers face that sort of a situation. At one time, 70% of the total community kitchens were run only in one state, that is Kerala. The community kitchens were set, the guidelines were issued by, for all these activities, guidelines will be issued by government. And this, once the 5 o'clock or 6 o'clock, the CM comes and states something, next day it will be put into practice. That's the capacity of the local governments. The ward councillors, you know, you have got a elected representative for around 2,000, 3,000 people. And they take up the leadership. That's exactly what they have done during the flood time also. They know what they are expected to do. And the resources came not from the government. Most often it was a local collection. People collect themselves. And they paid. And I'll just stop to answering that one with one more statement. And I was quite impressed. You know, nowadays they run special trains and all the trains are suspended, except the special trains now. Therefore, you will not have shops and the eateries in the railway stations. When the guest workers returned from Kerala, the state has actually fed them and gave them each a food package till they reached their home. That was the way in which they were actually treated. That is unique.
I think we have a lot we can learn from that. That's something that I think, yeah, a lot of the world right now, and especially North America, can really learn from you guys. Dr. Hayek, did you have anything that you wanted to mention perhaps about what the response is going on currently in Vancouver?
In Vancouver, yeah, so I could just mention that in Vancouver, we've been lucky. So I think we also have some similar measures that were put in place. We have, I think Dr. Bonnie Henry has been instrumental in our response. She's provided great leadership, and she has a slogan of kind of, I think it's, be kind, be safe, and I missed one, be careful, I think. Someone can help me out here. But you know, it's just I think that
be calm, be safe, yeah.
Be calm, be kind, be safe, and just the idea that you're being looked after is nice. And she is kind of transparent, clear, and has had good messaging. And yeah, I think part of it we were quite lucky. I think we didn't have some super spreading outbreaks, and we were prepared. I think our lab also tried to diagnose cases early. So we were overwhelmed at one point that we had too many cases. We couldn't test symptomatic patients. So we just said, everybody, you're potentially infected, everybody just locked down. And then when we ramped up our cases, we were able to detect cases. And now our case volume has gone down tremendously. In the hospital where I'm working, we only have 4 patients in the whole hospital, in the Vancouver General Hospital. And case numbers are low. I think in the whole province there are only about 10 people in the hospital, and we've not been overwhelmed. Other parts of Canada have been more affected. I think our kind of the main things that happened here in Canada were nursing homes. I think that's one thing that had highlighted that in the vulnerable older adults in these nursing homes, they were really tremendously affected. And it shed a light in the care that were provided in some of these nursing homes. It was really egregious. It was really terrible care that elderly people were getting. And it just showed how this COVID really took advantage of that. And a lot of, I think about 70% of Canadians who died were over the age of 80. And most of them were probably living in nursing homes. And then the next thing that happened here, we had their biggest outbreaks were associated with slaughterhouses, actually. So the way we raise animals here for food is we kill them at these massive slaughterhouses, and it's a big industry, big money, and lots of vulnerable workers go there to work. so there are new immigrants to Canada, guest workers, people who've just arrived. They often take these difficult to work jobs, and they're in close quarters, and they've had big outbreaks in those settings. So those are, I think, the two things that affected the response. And I think going forward, hopefully we'll take some of the measures that you've had there in Kerala to make sure that we do support those most vulnerable, because they do kind of make it worse for us. But as far as our place here in Vancouver and BC, I think we've been very lucky. I think.
Absolutely, I think you're right, especially when you compare to some of the other provinces, and we were hit fairly early, but numbers seem to have stayed relatively low.
Yeah, and I just think too, as a country too, I think we've had a lot of. I was quite impressed with the amount of support that we had for people to be able to endure the lockdown. I think that helped a lot as well, like cash and payments for people unable to work as well.
Absolutely. That is something that I think has highlighted the Canadian government has been prioritizing speed over sometimes efficiency, but everybody's getting support. But yeah, I really appreciated both of your input. It's actually inspiring. It's really easy to get a lot of the negative stories and just looking at numbers without seeing kind of the human response. And so I really appreciate both of your input and kind of pulling in, seeing some of, giving us a little bit of a light at the end of the tunnel, or maybe not quite at the end of the tunnel, but at least something to look forward to and say, okay, this is what's doing well, and this is what we can focus on moving forward. Now, we do have some great questions that have come in. So I'm just going to start off with one from Sanjeev. And they write, a lot of emphasis has been made by the national and state governments that there is no community spread. How sure are we of this? What are the public health implications of denying community spread when it is already these?
The community spread, they usually conduct some surveys. So initially, the test kits are costly. You should understand that all the costs are borne by the state. They have got certain limitation. But still, there were tests conducted, and some of them, less than 100, I do not remember the exact number, turned out to be positive also. But so far, of the 1,000 cases, except 2 or 3 cases, all the other cases could be traced to some contacts. So the testing is based on certain guidelines, and so far we do not have evidence to indicate there's large scale community transmission taking place in Kerala. I do not know what exactly the situation in India, because the government is extremely shy of sharing the data in many parts of India. Therefore, we do not know exact situation. But everybody is hell-bent on denying it. But technically, I think there should be some going on, maybe 0.1% or maybe even less than that. In some of the hotspots, it may be more. It's only a guesstimate. I do not have actual figure for that, because we cannot access it, the data.
I would just say that it's an important point. I think it's good to know if there is community spread or not in your response. And so I think, and I think that in India, it's a huge country. And so I think parts of India are, and I've heard that maybe in around Mumbai or Maharashtra, I think there's more cases. And so and I think that the government has kind of tried to make hotspots and green areas, red areas. And so definitely when there's community spread, you have to be, like, even in the hospitals, people have to be much more careful to treat every patient as possibly COVID related. You might have to cut down some non-essential services and different types of response. And then one of the kind of, I think, the clues that you're having community spread is, and we're still sometimes seeing occasional cases where you don't know where it came from. you're like, well, I don't know any contacts. I don't have a known contact. And in those situations, it's very concerning. And so you have to have more stringent kind of quarantines and these kind of public health measures. Once you're seeing just cases of known contacts or someone who's coming from a different high incidence area, then you can adjust your kind of public health response. So that's why I think it's very important to make that distinction, community spread or not community spread.
Thank you. That's great answers from both of you. Ava had a question. She said, hi, I'm wondering two things. Number one, in the first few slides, you mentioned that Kerala has 36% doubling rate. Can you please explain what this is and what factors impact it? So we'll start with the first question, then I'll go to the second.
So the doubling time means, once we are initially told quarantine period was for 28 days, double the maximum non-incubation period. And we are testing, once test becomes positive, all his contacts will be traced also. So that is actually has helped us to contain the infection among those who are quarantined only. That was a success. That's why the doubling time could be reduced. And the number of tests could also be reduced. Rather than testing indiscriminately, tests were also used more effectively, efficiently.
Okay, perfect.
And one more point is, initially we were expecting people from other parts of the country to come with disease. Therefore, we are specifically focusing on people returning from other parts of the world where hotspots are there. So these two strategies helped us.
Absolutely, that makes sense. Her second part of the question, number two, was you mentioned that Kerala has people-centric public healthcare system. Is this common throughout most states in India, or is this is this an exception for Kerala? And thank you so much for sharing your expertise with us.
That's a difficult question as far as I am concerned, Emily. Basically, because I live here, I work here, I was an activist also. My knowledge is totally dedicated to Kerala. Other parts of India, you have got a structure, but I don't think, again, I told you, my experience is very limited, but I don't think, not to this extent. And one thing I can vouch is that here the primary healthcare is, the responsibility of providing primary healthcare is rests with the local government. Primary health centers are managed by local government. In other parts also, maybe these sorts of laws are there, but I told you that's why I have put that Da Vinci picture over there. In theory, it may look something similar, but the way in which it is being implemented is really different when you compare with the other, especially North Indian states. South Indian states, there may be some similarity.
That makes that nice. Thank you. Jitesh has a question. They say, hi, my question, how the strategies implemented in Kerala can be used for the states where basic infrastructure, literacy rates, political commitment, and local self-government are not as good as Kerala.
Very good. When you feel hungry, Emily, you have to plant your paddy or whatever plant trees that you want to grow. If you want to eat something, you have to plant an appropriate time. During crisis, we need to look something different, not actually. But at the same time, one thing I'm sure, each society will have its own innate nature of survival instinct. If one society is facing, say, whatever you are saying, it is not applicable to me, then we'll have to find out some innate strength within the society, which we can very well find out and tap that resources to overcome the crisis. Once crisis is overcome, plant your trees.
Very wise, wise words. It's very true. Vidu had a question. Thank you for the great presentation. It is inspiring and provides hope for the rest of the country. I would like to know if Nipah's elimination was a result of some continuing efforts beyond June 2019, so vaccination perhaps. Additionally, if you can share what is happening in Kerala for COVID in terms of medical research.
Fine. Nipah, there's no vaccine for Nipah. The strategies that we are using for corona, more or less same way, was tested and proved for Nipah. That's why we could actually adopt it easily. But Nipah, I told you, it's a disease which has got high fatality compared to that of corona. So once you can pull on with Nipah, then you should be able to pull on for corona if your strategies and your activities are perfect. That's with regard to Nipah. Come to the other one, research for corona. Kerala is a state here. The state government is existing its hand-to-mouth existence now because their resources was really stretched. They cannot actually manage the situation without the support of the government of India. Therefore, to take up research at the level of the state is really challenging. So as such, we do not have that much research going on as far as the corona is concerned in the state. But I say the government of India level, they are doing something.
Thank you. Vidhu had another question, which was, would you consider Keralites to be more resilient or immune? Any active testing on immune status of infected patients, which can possibly provide more information on protective antibodies? Which I think is a question that we are wondering everywhere around the world.
Can you say it again, once again, please?
No problem. I'll say that again. Would you consider that Keralites are more resilient or immune? Are there any active testing on immune status of infected patients, which can possibly provide more information on protective antibodies?
Very good question. Kerala, see, any society, any community, any human being around the world will be resilient when they are threatened with the question of very existence. Only thing is the society should be led from the worst scenario to a better scenario. Collective thinking, collective working, that's the only way by which we will be able to overcome these sorts of challenges. Coming to the native immunity, you are mistaken. We are also Homo sapiens, 46 chromosomes, and the people living out here may be having ancestral lineage to different races around the world, and therefore I do not consider. Only thing is you are speaking a language which is alien to many others. That's all. Other than that, I don't think there is any peculiarity with regard to immunity or anything.
I'm just going to comment. I think maybe there is something with Keralites. It's probably not, but there is some that social fabric or these things that you talked about. I think those are the things. I don't think it has to do with maybe your genetic kind of things, but there is something there that happened. And I think just to comment that in the United States, we've seen a big difference in say, Black Americans compared to white Americans, the way that they've been faced. And people say, oh, it's the race and things. But really, a lot of it is just that they've been marginalized and have all these bad outcomes already. And so here comes a disaster. Okay, well, you're going to be more effective. Maybe in Kerala, you've been supported. You work together through disasters. Here come another disaster. Well, this is kind of what helped Keralites. Maybe from that's what I took from your talk. That maybe that's what helped you guys stay together and have that immunity and resilience for standing up to this kind of COVID pandemic.
And I'd just like to say, I'd just like to add to that, Dr. Vijayakumar and Dr. Hajek, that I teach public health at UBC, and often the sort of first thing that we do, like a public health 101 lesson, is to teach about the social determinants of health that Kerala has taken such good care of. And you gave a beautiful illustration of that today in talking about food and housing and treating everybody as equal. Like, we've heard stories of other parts of India where migrant workers have been treated really badly, like really badly. And you're even using different language to talk about them as guest workers. So there's an entire infrastructure in Kerala which has been there for decades. And so when you're able to have a strong infrastructure and strong local support, because you stressed the decentralized support and the volunteerism. And I think all of that has been there for so long that when a disaster strikes, Kerala is ready.
Yeah, I agree 100% with what you're saying, Dr. Schroff. I think too, when you talk about stress and the impact of stress on the immune system, and if you have a group that are all well supported, that does impact the overall experience of each person individually. And so it's not to be underestimated, the fact that you have an area that is better supporting its people, and that actually affects their response to how their body actually processes something like COVID, but, and nutrition and actually being able to eat. Yes, go ahead.
No, yeah, just answering your question and adding to what Emily and Farah was saying. One thing is, of course, the social fabric is a little different. That I should tell you. Right from mid 20th century, Kerala, early part of the 20th century, somebody was calling an lunatic asylum. But because of the strong social movement, political movement, especially in the mid 20th century and post independence, Kerala has evolved. The society has evolved a lot. But it took a beating, especially with the globalization, post-globalization, liberal views and all those things. Actually, the last few years, we saw the reverse. They say, everybody realized that this is not the right way. We need to take care of each other, because globalization led to a culture where, you take care of yours, so don't bother about anybody else. Now again, last certain contingencies of catastrophes taught us the reverse, that we need to take care of others also. That's sort of a change in thinking in good proportion. I'm not saying everybody is like that, but good proportion of the people, that sort of realization was absolutely there. And coming to the stress part, I should add that I couldn't find that, because I have got reasonably good contact with the lay people around the state. When the chief minister says tomorrow it will be done, people believed in him and followed whatever he has actually told them. And therefore, they had reasonably good trust. Even the political parties which were on the opposite side of the ruling front was also having really good trust with the administration. Therefore, the stress level was, I think, minimum. And many of us, you know that there are certain projects going on, estimating the post-traumatic stress and all those things. But I'm sure that our initial findings are that it was not that much.
Thank you for that input. We have, I think, 3 or 4 more questions, so we'll probably go a little bit over the hour. But I think this is all very interesting. I think everybody's interested to keep on going. At least I know I am, and I see a few people nodding their heads as well. So if everybody's okay, we'll just keep on going with some questions. There was one actually a bit on the similar topic, but Canadian spin, is that the question was, is there an explanation why BC has different numbers compared to Ontario and Quebec, who, for those of you tuning in from India, those provinces have been the hardest hit in Canada? Are there different strains, different parts of in each part of the country that are more contagious or serious? So Dr. Hayek, you might be able to comment on that one.
I can try, but I think it's not known. I think it would be merely speculative and kind of guesswork. I think people have, that in some cases there have been clear, same with, I was in Toronto for SARS, and there we had one person who spread to other people in the emergency department, and it led to outbreaks. I have not heard that in Toronto or in Ontario or Quebec, so I'm not sure what happened. Some people think that it was the schools. There were some schools that their holidays were different, but I don't think children were really part of this kind of transmission. So I'm not entirely sure. I think some of it was luck. I think some people. Helene Bertrand has put up her hand.
Yeah, is that okay if we let her speak? She's a family physician who's worked in Quebec. Is that okay, Dr. Hayek, if she responds?
Yes, I'm happy to have, I think it's just kind of guesswork, and I think I would like to hear other people's opinions as well. I don't think I have I don't know the answer there. I'd like to believe that we've done the things that Dr. Vijay Kumar was talking about, that some of that help, that we looked after patients here, that we took special efforts to look after more vulnerable people. But I'm not totally sure about the right answer there.
Something you have to understand is that Quebec and Ontario are very, very close to New York. And there are a lot of American visitors to Ontario and Quebec from New York State and New York City, which are the most severely affected parts of the United States. And therefore, the chance of contagion over there is much higher than it is here out west. The other question I wanted to ask is, in Kerala, what is the average age? Because this disease affects older people much more than younger people, and I'm wondering if there are fewer older people in Kerala, or if there are, like, diabetes is another very common cause of mortality. What is the incidence of diabetes in Kerala compared to the rest of India?
I'm just going to mention one thing about the New York and United States. I think it's a good point, but we have Washington State near us, and they were really struggling too. We had lots of, and our numbers look quite similar of the initial, how many patients were kind of coming into the province compared to, like, proportionally. So I think it's a good point. You have to think about people entering, but there may have been more to it, because we did also have people coming across the border quite a lot here from a high incidence area, and also dramatic, like they did much better there in Washington than they did in New York City as well. So some things are going on that are not totally explained, and I'd like to think it's attributed to these social determinants of health and the ability of communities to follow through these kind of I like how you said people-centric public health approaches.
Yeah, I love that. We have sorry, go ahead.
Helen, I hope you remember your visit over here. The proportion of elderly in Kerala, 60 plus, is over 15%, 1-5. And the prevalence of diabetes is 20% in the adult population. And hypertension, 30% in the adult population.
Wow.
So a lot of speculation going on then. We're just going to continue because there's 2 more questions I wanted to get to. And then after that, if we've got time and people are still interested, then we might put some raising of hands and have a bit of conversation going. But as far as the recording, I'd like to get the last couple of questions done. And then we can just have a bit more of a free flow conversation. So there was one by Jazz. They said, "Hi there. I'm also a recent public health graduate from Vancouver and very grateful to be attending this seminar. I'm curious what efforts Kerala specifically made to protect their most vulnerable sectors and populations. What specific strategies were used that we can all learn from, specifically thinking about the outbreaks in long-term care homes, as we've mentioned in Canada." And thank you. So I think you did mention some of this with, like you were talking about taking care of and feeding and caring for all of the population, but maybe you've got some more things that you feel Kerala has done specifically?
Are such institutions were restricted? They have restricted their visitors. And the rest of the thing is same. Sanitizers, taking care of keeping we don't even say social distancing, physical distancing and social proximity. Taking care of maybe using mask, hand washing, these sorts of things, no visitors. These are the specific measures adopted for these care homes.
Okay.
And all the quarantining and the contact tracing and containment procedures were protecting the general population, because the disease is coming from outside. So if you are vigilant and you are able to manage it properly, you don't have to bother much about others, provided everybody keeps to the general overall description, suggestions.
That makes sense. There is another question, Haifa. Yeah, Haifa. Hi, this is Haifa from Kerala, one of the recent public health graduates, and it's great listening to Dr. Vijaya Kumar, and the PowerPoint was really great. It would be great if he could explain a bit more about the support given to people who were quarantined. So quarantine-specific support.
So those people who are put in quarantine, they are entitled to their daily rations. The supplies were made to the doorstep, either by government agency or by the volunteer groups. We have got a different side. That's the role of the local government. They ensure that those who are put in quarantine will get whatever they require at their doorstep. Number one. For any sort of disease or any consultations, their anxiety, even for tele-counseling was instituted. You can call a number, they will just address your questions, and if at all it requires somebody to, is essential that somebody should visit the doctor, then there was guided transporting arranged specifically for that sort of. So quarantine was not totally an isolation or something like a jail. I don't know what happens in jail, but still, you know, the services were taken care of, and including health or maybe daily subsistence materials.
That's very humbling for, I think, especially our American counterparts, just to hear those things. All right, so I think you had mentioned, there was a question about whether Keralites were given flu vaccines, and I think you actually replied and said that you don't give regular flu vaccines every year. There was another question that had come up, which was, Kerala is often ahead of India with respect to health and human rights. It is also the birthplace of Ayurveda. As you know, Maternal Infant Health Canada is carrying out a study on Ayurveda and yoga for the health promotion for women and children. And generally in Canada, any mention of alternative medicine or like Ayurveda, Chinese medicine, naturopathic medicine, supplements, all of that is very much not part of the COVID-19 response. And it's been quite quieted, we'll say. Now I'm wondering, do you see a role for Ayurveda or yoga or any of these alternative medicines in the prevention of COVID-19, specifically in Kerala or just in general?
I don't know about India, not in Kerala. But each was got its own relevance in a different domains. But in terms of controlling or preventing the, managing the epidemic, they do not have much.
It might go back to your previous comment about when you treat the immediate epidemic and then you look at the greater picture as we move forward. So there's the immediate and then there's the kind of the long term. Thank you. Now, somebody did have their hand up earlier. Let's see. There we go.
Dr. Phillip.
Yes, Dr. Phillip. I see the hand is still up. So maybe we can unmute Dr. Phillip and you could ask the question. Go ahead. Oh, I think you have to agree and unmute yourself. There we go. Go ahead, Dr. Phillip.
Hello, can you hear me? I am Dr. Phillip. I am a disciple of Dr. Vijay Kumar, sir, and I work in ILP. I have been close to the epidemic right from the beginning. 2 points I wanted to add regarding that stress part. The very minute the first case came, the minister came and there were 16 committees, 16 sections, and one section was psychological counseling. Actually, to all those people who were in quarantine, the MO from the PHC called, from the district control cell they were called. So this, like Vijay Kumar sir said, this telephone counseling and dedicated online counseling helped. And for those who required additional care from the psychiatrist, that too was provided. This was done all over Kerala. Regarding this, one of the questions which were addressed regarding homeopathy Ayurveda, I was also part of the capacity building process in my district. And the district collector in the initial phase itself, invited the DMO Homeo, Ayurveda, and we had common sessions where we discussed what should be communicated to the community. And 2 points were regarding the treatment part, whatever the state said in unison should be followed. There should not be any trials like a homeopathy trial or Ayurveda trial. The treatment part, it is as per guidelines and protocol. But regarding the educational part, we were in the same tune. We propagated like hand wash, then wearing mask, and then social distancing. And Ayurveda, they even improvised on the mask. They made an Ayurveda sort of mask, which they said that would be good for the community. So I think the Ayurveda homeopathy teams were also taken into confidence in my district. I know more of my district. One more point which I wanted to add was like in Pathanamthitta, when the 5 cases broke out, of course there was panic in the beginning. The first day, many houses were quarantined. Maybe an entire area was quarantined. So the first day they were stressed because of food. They thought, what will we do about food? But then the very next day, as Vijay Kumar sir said, the local self-government ensured that they received 1 week's supply of food. Not only food, there were people with diabetes, there were people who were on medicines. The medicines also were made available. And later, in the later phase of the epidemic, the PHCs ensured that those with, and during the lockdown period, there were special efforts to ensure that medicines were given to the chronic patients through the the ASHAs. ASHAs is accredited social health activists, a part of the government health system, volunteer part. So these were the points I wanted to add. And I have also thought that we have some resilience. I think some community resilience we do have when compared to other states. And also, I think we stand apart because financial decentralization is there till the local self-government, which may not be there in other parts of India. The local self-government, if they want, they can spend money for a local specific project, uh, provided the health center, the community, and they have undergo certain processes. I think these are our success points, and it didn't come all of a sudden. Incremental investment in social and public health for the past 20 decades. Thank you.
Thank you so much for your input. That was fabulous to know and hear what's actually happening in your experience. There was one last question, and then I think we might kind of wrap up and thank everybody. And it was just because it seems to be a little bit on the topic that we are talking about here about we've talked about primary treatment, but there was a question about whether either of you, this is for either of you, that whether your thoughts on vitamin D deficiency do have a relationship to COVID-19 cases. So there has been some talk about the deficiency and its effect on the spread of the virus. So do either of you have any experience or comment on that?
So far, we do not have any data on that front. If you ask me an opinion, I don't consider it as an important thing to pursue, but theoretically, there could be something which we have to explore. As such, we do not have any evidence to indicate like that.
I would just say that there's been a lot of interest in some treatments for COVID-19, and some of them have not been very carefully thought out, and you know, I think it's good if they're safe and there's not much harm in it. I would support that. And I think malnutrition, and if someone is not getting enough vitamin D or things like this, to best support their care. So if it's something that's a generally healthy thing that will make the person's overall health better, then I think it should make their body even more resilient to COVID. But as far as saying, I've not heard any evidence that taking vitamin supplements of extra vitamin D will help you prevent COVID or overcome the disease more. I've not heard that, but I think there is a lot of interest in these kinds of relatively safe interventions that you can do to help mitigate the health risks of COVID.
Yeah, I think the key is differentiating what's treatment and what's just general support for, you know, feeling strong and healthy, like what you would normally do in the flu season, as opposed to, you know, really differentiating what we're doing to actually treat and prevent and what's just a good practice to do. And I think that's probably where a lot of the confusion, but there is We are seeing even in New York, they're talking about vitamin C, and then you're hearing these things, and it can get quite heated and kind of defensive on both parties. So it's really great to hear both of your thoughts on the topic, and for everybody to keep in mind that it's two different topics, whether you're treating versus whether you're just supporting general well-being and health, which that includes mental health and support. And I really liked, thank you so much, Dr. Philip, talking about how you have added in counseling services. I think that is something we can definitely learn from here and around the world. So this has been a really fabulous seminar. I really appreciate so much, Dr. Vijayakumar, Dr. Hayek, how much you have shared your wisdom and everybody's comments and questions. It's really been a fabulous, fabulous seminar. So thank you so much for taking your time and sharing your experiences. And thank you everybody for showing up. It's lovely. I can see some of your faces, not everybody, but I definitely appreciate everybody tuning in, because I know it's early in some places, extremely late in other places. So yeah, thank you everybody for joining us. Farah, did you have any, Dr. Shroff, did you have any last minute things you wanted to say before we shut it down for the day?
I wanted to thank you, Dr. Solomons, and Healthy Seminars, and Lorianne, and Dr. Lauren, and all of you for your generous support of Maternal and Infant Health Canada. And just to let everybody know that we do these kinds of webinars every 2 months, and we welcome all of you back. In 2 months, we'll do another one in July. Please check our Facebook page, Maternal and Infant Health Canada, and I put the website ma.med.ubc.ca. So we'd love to have you back. And thank you so much to Dr. Vijayakumar, coming all the way from Kerala. You put so much effort into this. It was really amazing. And, you know, Kerala is always such a bright light. It's just great to hear that. And Dr. Hayek, awesome, amazing to have your insights from, you know, your expertise from Canada, and you're a tropical disease specialist. So you've got the perfect balance of what we needed for this. You've got the Canadian experience, plus you've got the international experience. And it was just a delight to have you here. So thank you so much.
Yes, it's nice to have a little positive. I like it.
Yeah, very hopeful.
Thank you. Thank you, everyone.
All right. Take care, everybody.
Okay.
I will thank each one of you.
Lovely seeing you all.
Basically,
Bye-bye.
because it's extremely difficult to bear me. That's what at least my wife says always.
We were very happy to have you, Dr. Vijayakumar.
Absolutely.
Tell your wife to join us next time.
Right. Thank you.
Thanks, Nina. Thanks, Ellen, for coming. Yeah, thank you.
Bye, everybody.
Bye. Bye, everybody. Thanks for coming. Is it John Scott? Jay Scott, are you John?
Thanks, Farah. That was great. That was interesting.
Yeah, so glad that you joined us, Lauren.
Good to
Come to the other ones, and you got to meet Dr. Vijayakumar too, and Dr. Hayek. Yeah, and so Dr. Hélène Bertrand, who made a little comment, has just been to Kerala to be at Dr. Vijayakumar's university. So we'll hope Dr. Vijayakumar will hope to have you and Dr. Bertrand give us a report of how that visit went, and the lower back pain study that you initiated. That'll be the subject of another webinar.
Yeah, that was our January webinar, so that was great.
It went like we did the webinar in January, and Ellen was in Kerala in February.
Farah, what I love your group to put out as a webinar because is what they're seeing in the pregnancy and the babies with COVID. It'd be nice to gather the research. I think your group would be great if your group did that. I know there was a study we just saw about seeing the clotting in the placenta on this recent study, right? mom and baby are okay, but they know based on clotting the placenta that there's lower income and more cardiovascular disease. I think
and higher rates of impaired growth and like growth restriction.
So, but that's not. We don't know if that's the same thing with the COVID clotting, but it'd just be neat to see what data is out there, because more